So we are now recording. I'm going to go to screen share, and everybody should have my screen. And we're going to play. Right, let's see if we can minimize that. How do I get that down there? Okay, so we've got muscles of the shoulder and the arm. So we're going. This is the third week, trying to get that to go down. But okay, so we're going to go for recap of week 2. So when we're thinking of the femur and the humerus, we're thinking of a little person. Remember, what we're trying to achieve here is we're trying to think of really, really easy ways, because I think of remembering stuff, because when we try and be too true to the, let's say, like educational text, and we're trying to remember these long words and it becomes intimidating, I think it's harder to retain. The sillier the analogies, or the simpler they are, I do think it becomes a lot easier, because you picture things which you're familiar with. If you're not familiar with something, it's not going to stick. That's my take on things. So when we're saying we've got a femur and a humerus, it's a little person. They've got a head, they've got a neck, they've got a body, they've got little arms, and they've got little legs. And these arms and legs are tubercles if it's an upper body. So if it's a humerus, it's a lower body, it's a tuberosity. And in both of them, they are epicondyles. So the thing that I really like from a biomechanics perspective, and it really helped me tremendously when it came to remembering things, was the fact that the blueprint of the body and of the upper body and lower body are the same. So the mechanics of the shoulder and the humerus, and then the going further down, is pretty much the same in the lower body. Your foot and your hand are very, very, very similar mechanisms, very, very similar types of things going on there. Obviously, there's a lot more freedom of movement in the upper body, a lot more stability in the lower body, but it does repeat. In terms of the rib cage, what you need to remember through there is just really attachment points. It's quite I would dare say it, nothing's in the body simple, but it's a simple structure. But the main thing is we've got 24 pairs of ribs, 7 are true and attached to the sternum, which are vertebrosternal joints. We've got 8 to 10 are false, so the vertebral chondral, and then we've got 11 and 12, which are floating, so the floating ribs. As Aaron said, the common ones, I'd say, with the floating ribs is, from a training perspective, is the belt getting in the way, and now there can be a lot of pressure on those due to the fact that your belt positioning when you're looking to lift, because remember, you're trying to create incredible amounts of tension. If the belt is in the wrong position, those can get pretty uncomfortable. I've definitely experienced that in the past. So, yep, there's a ribs going through everything so you can see. The thing that I would say is very, very useful, why you have a kind of a good concept of the anatomy of the rib cage. Is because in stuff that I will be going on about in either future seminars or lectures, and it's becoming popular at the moment, is this a concept called the infrasternal angle. It is very it's an important measure, but the infrasternal angle is, if you can see that blue sternum in the middle, there is a little projection at the bottom pointing down the xiphoid process, or your xiphy sternum. Now that, if you were to draw a line straight down to the floor, and then as soon as you hit an angle, so as you can see, if I was to go like that, and then you'd meet the ribs, the angle in between there is something known as the infrasternal angle. It's not really, I haven't really come across any mainstream British coaches talk about it. There probably are a lot, but I haven't come across it. It's very popular in America. I was looking into this from a clinical perspective, because it does bear a lot of relevance when it comes to shoulder injuries that just don't go away. And there could be some impact of ribcage positioning, which is infecting somebody's shoulder and breathing mechanics. So the concept of the ribs is this infrasternal angle, which is malleable. It can change, so it can change depending on the individual, can change depending on their activity levels, but it's generally genetically determined. That plays a big factor. So the way you're built comes into it, and it does change your lifting mechanics. It makes you suited to certain tasks, but again, it's not the purpose of this lecture. However, it is something to know, and if you can imagine that, if someone says the ISA, the infrasternal angle, that is what they're referring to. It's the point, the xiphoid process going down, and then it's that angle until you hit the false ribs. Okay. So what do you remember from weeks 1 and 2? Just dead quick. I'm not going to be cheesy and do the countdown noise, but if you can just remember, go through these and look, go through all the different ones, because remember, we want this to stick. You should look at these and they become very, very easy. If this is the first time attending, I can appreciate that it's going to be tricky. Don't worry about it. We will go through in a second. But if you did attend last week, you'll know there's 4 extras there, which is the trochanter, linear aspera, epi, and condyle. So I just want you to quickly jot down what they all mean as a prefix or suffix. So let's go through there, and I'm just going to see if I can. Aaron, have you ever come across infrasternal angles in osteopathy in any text or any?
No, it's something we did when I was in my master's program, when we were talking about angles pronation at the pec muscles and how that would change what you're doing with the humerus. Yeah, in terms of osteopathy education, never talked about it.
No,
which is interesting, because I think it's a really, if you understand that concept, I think it's actually a really useful thing for programming.
Oh, massively, mate, massively. It's you know, I think the thing that's very, very interesting is that if you can just look at a picture of somebody and you can see it.
Yeah.
And then the impact it has is quite, you know, it's very, very relevant. It is very, very relevant, because you can work on somebody's bicep or shoulder or neck for quite a while, but then if the position of that rib cage just pops them back into that, you know, position that they can't, that's causing the issue, then it does come.
I think that's the potential why, you know, some people get no activation of the pecs from bench pressing, and you know that it actually changes your program design as a result as well. Yeah, no, it's something I came across. I did an exercise physiology masters and it was on there. But yeah, osteopathy was much more like, well, we learned some really bizarre stuff. I don't know whether it's the same for you. My anatomy exam, my 4-hour anatomy exam, we had to describe the tributaries of the internal iliac artery. That's how in depth it was. It was like we were going to be microvascular surgeons and therapists.
Yeah. Wow.
Yeah, 4 hours of writing that. It was stressful.
Right. So sorry, I've got a
question, Chris.
Can you get the question to come up? For some reason, the cursor isn't working on mine.
Do you want me to read it out for you?
Yeah, please, could you? So
this is from Alina. Chris mentioned American coaches talk about intrasternal angle, or UK ones. Do you have any specific names?
Yeah.
Articles.
So Bill Hartman, he's been on the podcast. Bill Hartman's just a phenomenal teacher. He's one of them where he's popularized it, and what I love about him is that, like, because he's helped people understand it, he's then not said like, oh, this is mine, I've taken ownership of it. He's purely said this has been around for years, but it's very popular with PRI, which is the Postural Restoration Institute, which is the acronym for it's very more down the therapist route, but some very intelligent coaches are able to apply it in the gym. So yeah. Okay, right, so let's get this moving. So hopefully you should all be able to see that. Don't know what, there we go. So if I go there, down chat, spectrum is green. Spectrum is green. I'm not sure what that one means. Let me see if we can skip that. Okay. Right. So everyone can see we've got fossa, we use cave, trench, supra above, infra below, sub underneath. Spinatus, so any atus is of the, spin is, you know, spine, scapula, scapularis and scapula. We have inferior lower down, superior higher up, greater bigger, lesser smaller. Ramus is a branch, tubercle is a notch, tuberosity is round, trochanter is wheel. So that was I was trying to figure out something that'll help me remember it. So that I found that it was the Greek trokos. So that's where trokos comes from, the trochanter. If you think about that wheel motion, or in the femur itself or the acetabellum itself. Linear aspera is rough line. Epi is over or upon. condyle is lateral. So even though the condyles are medial and lateral, it just helps it's on the outside, the outer bit of the bones. So that's why I want you to, if you can remember that, and I've had some really lovely feedback off people getting in touch saying that anatomy is a lot simpler to them because of these, because of understanding this, and it's been great. So if you nail these, you're in for a good time, and you can almost, it's like one of those things, say what you see. So going into the muscles of the shoulder and arm, have we missed a bit? No, we're all good. So going into the muscles of the shoulder, the arm, so muscles are broken down given their jobs. So we have some flexors, extensors, prime movers, and managers, which it's not a academic terminology, but I say we've got managers and movers, and managers are just those deep tissue, the deep muscles, which are managing the joints on a very, very deep level. And then we've got the movers, the ones that help us propel ourselves and take ourselves forward. Again, that's not academic literature. It's just a way of remembering it, is that we've got a layer on the top, which everybody sees and it looks great. And we have a layer underneath. And it's the layer underneath that usually have the issues or aren't working properly, which gives us any kind of joint issues or dysfunction. Now, external rotators generally as a guide for stabilization. So they're going to help us create stability. And it's not necessarily, that's a very generalized term from a functional anatomical point of view, but they're going to help us stabilize ourselves when the need for stability is very, very high. So if you think about the eccentric of a squat or a deadlift, a squat or a bench press, so stuff where we have to really press things off us, we need strength in those external rotators to create stability in the scapula and the pelvis and guide the humerus and femur around the joints. So they're very important. You can see there's a guy here lying on the table who's going from external to internal rotation. Internal rotation is like a guide for force production. So they're the ones that help us when we're going to propel ourselves. So think punching something, bench pressing something, squatting something away. Where we're forcing ourselves forward, the external rotators are going to lengthen and the internal rotators are going to guide, whilst the extensors, so the extensors are pushing the, our arms or the weight forward, whichever one you want to say. So we generally have a higher number of stabilizers, but the crazy thing is, and I think that I don't want to confuse people, is that in the joint at certain positions, certain muscles switch the roles and then switch back again, which I didn't realize until I started doing the osteo degree. And then you realize that when we think of functional anatomy, it's in this person that doesn't move. And when we're screening somebody on a table, that person isn't moving. But if you think about when you're going into hip flexion in a squat, yes, your femur is moving in that socket, but your pelvis is also moving and it's rotating in different ways. And what happens is the length tension of those muscles, so it'll be lengthening, but then also shortening to guide the knee in the same plane. If it didn't, if you think about it like this, if when we squatted, if the only thing the femur did was externally rotate, if that's the only thing it would do, at the bottom of our squat, our knees would be facing that way, and they're not, they're facing that way. So again, I hope, I don't want to go into that too much because that confused people, but you've just got to kind of get your head around is that in functional anatomy, things change, and that's why you have to know your basic anatomy so well, so you can get your head around what's going on in the gym, because you actually might be getting someone to do something and then it's actually the complete opposite of what they need to be doing. So if anybody is kind of scared by that or worried about that, that is why the foundations are so important. Is that you know the basics and then you can get your head around more complex ideas. Okay. So the ones for today, we've got shoulders of the arm. Now the one that I want you to remember, and it's a really simple one because you'll come across it all the time, is brachii, which is of the upper arm. So as soon as you see brachii, we know that we're around that humerus area, so it's the humeral bone. Then the bony landmarks serve as explanation. So if we know the bony landmarks, we can pretty much, it's one of those things, catchphrase, say what you see. You know, if you know what the what everything's called on the bones, the muscles generally are named that. It goes from A to B. So if you think the Brachialis muscle, you got the coracoid process in the shoulder, so in the scapula, sorry, and it's going into the body of the humerus. So for the humerus is a brachii, we've got the Brachialis, and really it's, and I don't want to say it makes it's as simple as that, but it is to a degree. Know your bony landmarks, which if we go back are these, you know those, and you go into the muscles, and we're pretty sweet in that sense. So there's a reason why I've broken it down like this, and we've got all the muscles they're acting on the elbow. We've got the extensors and the flexors. Now, typically you might think, well, we're thinking of the arm. We've got your biceps and triceps, which is obviously the easiest thing to remember. It's very common. We're doing bis and tris, but when we think about the way these muscles are positioned and where they go, it really, really helps us in understanding a little bit more about shoulder mechanics, a little bit about arm mechanics and elbow mechanics, and what we can do to play around with different variables. Now, the reason why I've done 4 extensors and 4 flexors is because when we look at the legs, you say you've got quadriceps. Quadriceps is a massive, massive clue there. Quadriceps, 4 muscles of the anterior thigh. So they're, you know, your vastus groups and then your rec fem, and they're all extensors of the knee. And so we have 4 little muscles in a subgroup, which are extensors of the elbow and extensors of the knee. Now, the extensor you've probably not heard of, which is never something you're going to say you're going to train on the gym floor, is the anconeus, which is a tiny little extensor at the bottom of the elbow. That's one of those brownie point ones to know, but it does exist there. But we do have a 4th extensor, which is right at the bottom. So I wanted to break it up. So we've got this extensors, the triceps brachii, and we've got a long medial and short head, which is essentially, in essence, an upside down version of the vastus groups. So that's why, again, is that this isn't, you won't find this in a textbook, but it helps you remember. You got your 4 extensors, 4 flexors. So when we look at the flexors, we have 4 again. But then when we look at the hamstrings, because it's the same thing, flexor of the knee, flexor of the elbow. When we look at the hamstrings, we have a semimembranosus, semitendinosus, but then we have the bicep femoris, which is technically 2 as well. And what's really, really cool is that when we look at this, it's the same thing in the arm. We've got the Brachioradialis, which in essence is the short head of the bicep femoris, but sorry if that's a little bit too much, but in essence, the Brachioradialis is kind of the short head of the bicep femoris. But then we've got the Biceps Brachii. So, you know, brachii of the humerus. Triceps obviously means 3, so 3 heads on the back. Biceps, 2 heads, which go into your long and short head. We've got a long and short head in the bicep femoris in the hamstring, and we've got a brachialis and a brachioradialis as well. Now, what I think is really cool is that you can play around with hand position, so pronation, supination, or neutral grip, and then you're going to get more of a bias of recruitment in these muscles. And when somebody has elbow pain or they have certain issues that they need to work on, it's that hand positioning which is going to play a big role. Now, if you have somebody who does have shoulder pain and they're trying to do a bicep curl and they're in a supinated position and it's really, really painful, it might be as simple as just changing the grip. And you might be able to wing it to an extent, like you just say, oh, just go to a neutral grip or go to a pronated grip, and it'll work. And that's fantastic. If you do that, and well done, you've got the great initiative and that's brilliant. However, if you can go one further and understand why that worked, then that's even better, because you can replicate it. Because then you can realize, well, what were the, connect the dots. What was the issue that person was having? Why was that successful? What was really cool for myself just before lockdown was somebody who had really bad shoulder pain and neck pain. And I was just palpating them. Obviously, it's not something you could do now, but this shoulder pain was actually coming from the fact that their brachioradialis was locked up. It had limited supination and pronation, very, very, very much so. It just so happened this was the muscle that taken the brunt of it for whatever reason, and working on that helped relieve some issues and regain some range of motion in the shoulder. So that's why, you can have concepts of shoulder pain, but it can be coming from other areas. So leaving that up there in that point, if you think about the arm, We know we've got biceps and triceps. We're never going to forget that. But you just got to remember 4 and 4, 4 at the back, 4 at the front, Brachioradialis and the Brachialis itself. So I'm going to just stop there, and I apologise to everyone because I think they might know what's coming up, which is going to be the
penis drawings.
Yeah, the drawings. So yeah, the penis pictures. Yeah. Where is it? I'm sure I've got paint light. Okay. Here we go. Right, so when we're going to think about it here, so I'm going to be as really politically correct as I can, and that's just going to be the humerus. I'm not going to draw any of the anything at the top or bottom this week. But when we're talking about the biceps, I'm going to start off with the first muscle, which is the simplest one, which is the biceps brachii, and we've got this projection here, which is going to be the coracoid process of the shoulder, the scapula, sorry. And that's like this little finger-like projection that comes out of the front, which is near enough, on some people might be easier to palpate. I think if I just show you around here, it's not too far. I don't know if everyone can see. Can you see my share screen, or is it just it's just my screen, or can you see me at all, Aaron?
I'm just off the screen. I'm just looking for some anatomy diagrams.
Yeah.
Just see your screen.
I'll just see my screen. Right, cool. So you can't see me on it. Right, no problem at all. So we've got this little projection bit, which is the coracoid process, and we've got the we've got this. The first attachment of the short head of the bicep is going to go into that position there, which is relevant because then we can see that the biceps is going to act on the shoulder in some way, and it's going to come round down into this position here. Now the opposite side, the long head, and you just got to think about the long head is going through. If we think the goal of the bicep is to get to here, so we want the bicep to get to this point here. You can go one of two ways. You can go the short way, or you can go the long way, which is where you have to go over something called the supra, because it's above glenoid, because it's of the glenoid joint here. So this is the glenoid humeral joint. So the supraglenoid tubercle, it goes over and it takes the long route. So we've got a long and we've got a short route in order to get to the position where the bicep wants to go, which is this coracoid process here in the shoulder. So that helps us in that sense. Now, in terms of an insertion point, it's on something called the radial tuberosity. I should have done some different color. That would have made sense. The radial tuberosity, which is obviously going to be on the radius. So we haven't gone into bony landmarks yet, but if we're thinking about there's a radius and an ulna, the radial tuberosity is important, because then when we think about what it can do from a functional anatomy perspective, the radius is moving over the ulna. It has supination properties, so it helps us supinate to a degree. And if everybody kind of has their arm in a flexed position and they have their palm facing down and then just move their palm up, so they go from supination to pronation, you'll feel how your bicep does move, and it's contracting a little bit more as you go into supination. It feels a little bit more tense, and then when you go into pronation, it feels a little less tense. So it's that's one thing from the functional anatomy. Why that's the case is because of where it attaches into the radius. Now, something that I think is really rather cool or important to understand. It probably would have helped if I'd gone with a different color. But when we look at if I draw this again here, so we've got another humerus. Is we have a quite, well, I would say a meatier muscle, which is it's powerful in its kind of anatomy. It's anatomically quite strong, but because of its attachment sites, it doesn't have the greatest moment arm because of the distance between where it attaches. But this is the brachialis, and the brachialis is just of the brachii, so of the humerus. Now this one, which is key, inserts onto the opposing side. So it goes into the coronoid process of the ulna. So that's if you, as long as you know it's the ulna, that's the main thing. Coronoid, not coracoid, which is at the top, the coronoid process of the ulna. And this is quite a strong muscle, but due to the fact that it's on the opposite side, it's on the opposite lower arm bone, so the bones of the forearm, because it's on the opposite side, it doesn't have supination capabilities, and it's going to play a stronger role when you're in a pronated position, which is why pronated movements, so palms facing down, are going to target the brachialis quite a bit more. And it's obviously because of that the case, when we're doing pronated movements, we have made the biceps brachii slightly weaker, and that's also because the tendons have crossed in that biceps brachii, which I think, I'm not sure, I've read in some textbooks, they say that it reduces a little bit of neural recruitment because the tendon's twisted. Have you ever come across that, Aaron?
Yeah, I think obviously you've got the musculocutaneous nerve that supplies those three muscles, and it's a big nerve pathway through the elbow. As you go into pronation, you start to change the neural dynamics as well as the tendon dynamics. So yeah. I've read some of the stuff.
Now, it's really cool that Aaron said that, because so I don't want to go down the rabbit hole of stuff like embryology, but if anybody's, we've got the time, but what Aaron touched on there is that if we look at neurology, that tells us so much about how we're kind of programmed to move. And what I mean by that is that these three muscles, their innervation, so their nerve, where they come from, the nerve that innervates them is the musculocutaneous, easy for me to say, musculocutaneous nerve. Is that right? Have we got that right? Spell it right?
That's close enough.
Close enough, it'll do. Musculocutaneous. It's C5 and 6, and basically it's the cervical vertebrae C5 and 6. And the thing which is cool about this, and again, I know we've gone a little bit on a tangent, is that even though neurology can be a little bit scary, like, oh my God, that's another thing to remember, it kind of helps us realize what needs to fire in sequence at the same time, in my opinion. And then, when we look at fascia, and when we look at these fascial trains, in a sense, if we look at neurology and we look at fascial trains, I like it when we see fascial connections, which also which correlate with the with muscles that share the same neural intervention, because that to me is like, well, these things all supposed to work in tandem in some way. And then when something doesn't share same nerve, it's not necessarily that it shouldn't fire in the same way, but I just like to think, well, why has the body done that? Why is that why is that important? What from an evolutionary standpoint, how would that be made, why would that be something that's been prioritized? So anyway, we've got the brachialis, which is going into the ulna. So we've got one, which is the so the biceps brachii, which is going into the radius, which is gone to one side, and we've got this smaller one, which is the brachialis, which is going into the ulna. Now, the brachioradialis is a muscle that can't really make its mind up, because it doesn't really know what it wants to be, and that's in that case of how it acts on the on supination and pronation. And one thing that I think is quite cool is it can do both, because it's going through and it's coming from this upper part, so it's coming a lot higher up, so this lateral part of the shaft of the humerus. So I'd say it's going to depend on different people, but I'd say from the lateral third, the bottom third, and it's going to go right the way down on the outside, and it's going to go into this the styloid process on the ulna, styloid process of the ulna. And the brachioradialis, the thing that's interesting about this is that when your hand is supinated, if it contracts, you go to neutral. If your hand is pronated and it contracts, it goes to neutral. So it's a neutralizing muscle. It's a muscle that neutralizes the forearm. And if you have, and this was the case with this person with shoulder issues, if you have supination issues, so you can't fully supinate, you can't fully pronate, which again is, in my opinion, something that does correlate to a lot of people's elbow pain, the inability to fully go through supination, pronation. I'd say that the infamous penis elbow in powerlifting, that's a big one, wouldn't you say? You've done
absolutely.
So it's because they lose the ability to supinate because they're fixed into pronation in the deadlift and in the squat, especially with a low bar squat. So that lack of supination is going to cause an issue. So that be able to rotate from fully supinated to fully pronated, we need that. Obviously, we've got pronator, teres, supinator, quadratus, pronatus in the wrist, and we've got all those guys that do all that. But mainly this brachioradialis, because it crosses the elbow in that fashion, is important. So that is one that's going to always take us back to neutral. So if we think about this from a training perspective, supinated, we hit the biceps brachii. Neutral grip, we're hitting the brachioradialis. Pronated grip or position of the dumbbells, we're hitting the brachialis. And that's why from that perspective. Now, if we go a little bit further down, and so if we go a little bit further down, we're going to go to the posterior view now, and we're going to go into here, and I'll keep this as PG as possible. So now we've got a terribly drawn scapula. We've had a couple of questions there. Is it right to read those out, Aaron?
Yeah. Do you want me to ask you the questions
now?
Yeah,
if you can just ask the questions there.
So there's a question from Tasha. So why in clinic, I think this is when we were talking about the classic clinical assessment versus a dynamic assessment when you were talking about that, Chris. Why do we do static movements instead of dynamic in clinic?
I'd probably say because of the population, and it's safer. And as students, it's like it's I wouldn't say it's a little bit archaic and old-fashioned, but I think it helps you deduce a more definitive answer, because it's something still trying to assess someone dynamically. So so much could be going on. So it's a really good point. But that's the thing which I'm big on, is to you screen someone statically to get an idea, but then you need to see how they move dynamically, because it may be a completely different story. But also, in clinic, it's a lot of geriatric patients in where I do the clinic. So statically is probably going to be the safest. In my opinion. So
I think it offers you a framework to start to understand human movements, because it's linear and it's pretty static. It takes out a lot of the variables that dynamic movement creates. The next question, this is from Tasha. Why have different hand positions when deadlifting, as this helps with grip, but does it create instability over time with the glenohumeral joint?
Wow, that's a really good question, but one which, like, I could go on about that for a very, very long time, because I'd say yes, it does. It does well more than that. It does tons more. I think it twists the spine to a degree. But then you've got these guys who are lifting 300-400 kilos and they look pretty damn fine. But it's just the adaptation. You look at someone like Dan Green, who can do 300 kilos for 10 reps. With a mixed grip, and his shoulders look pretty balanced. I think it's down to luck, it's down to people's genetic anatomy, but 100% from a functional anatomy perspective, mixed grip deadlifting does change the mechanics of the elbow and the shoulder 100%, because you've got a shortened tricep and a shortened bicep on the opposite side. So then when you're bench pressing, it will do, in my opinion. And there'll be guys who completely disagree. So I've done a mixed grip my whole powerlifting career, and it's one of them. But I just see how it can't not. It's like, would you squat with one foot facing at 90 degrees and one foot facing completely forward, 0 degrees? It's like, and I know the hip's a lot more stable and doesn't have as much freedom of movement as the shoulders, but still, I do think it leads to a lot of adaptations which can cause issues elsewhere. So if we go back to this, the triceps, well, first of all, we've got this little anconeus here, which is a little triangular muscle, which is going to be on the, it's right at the base. It depends. The thing about some of these is that you will get different anatomy books which vary. Like I've got 3 or 4 different books which have a different origins and insertions. But this anconeus here is just at this bottom point, in like so. and it's going on it's going to insert on the olecranon process of the ulna. So it goes onto the ulna, and it's at the very, 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 very base of the posterior part of the humerus. I personally think it's the muscle that helps us get that final 5 to 10 degrees of extension. So it's the joint manager, very, very small elbow manager. But again, people in some textbooks, it just says extensor of the elbow. So then we've got to think about now is that what I think is pretty cool is that we have this upside down quadriceps, so this upside down vastus group, and this long head of the triceps, the long head first is going to go through and it's going to insert on the infraglenoid tubercle, which is just below the glenoid cavity, or the glenohumeral joint on the scapula. So as we know, will be this lateral border, which is quite high. Now, I'm going to be honest. When I was, I first started training people, I had no idea the triceps inserted on the shoulder. Like, I had no idea for many years, and then it's just then you realise that why X leads to Y, and all this type of thing, and I think the most thing about the long head is that people will be very, very familiar with it, but long head is going to be when you go in arm overhead. So as soon as you point your elbows up towards the ceiling, you're lengthening the long head, which is going to change it. You're challenging it through its whole lengthened position, which is why it is why it's important, or why you can challenge the tricep in different positions, and you're going to be stronger, you're going to be weaker. So a cool little thing is, like, from a fatigue perspective, if you have your elbows pointing up towards the ceiling and you're doing overhead tricep extensions, you're going to fatigue at that. However, if you then go into arms by your side, arms closer, because you've shortened that long head and other heads of the tricep, you're then you've got a more mechanical advantage, so you can carry on the set. So that's a good way of torching the triceps, just through changing the position. And if you know your anatomy, then that makes a lot of sense. From a long head perspective, and again, I don't want to go too much into this, I think this can compensate with, and it can adjoin things with regards to the lat. I think there's a really strong relationship between the lat and the head, and this long head of the tricep when it comes to deadlifting, but we're not going to go into that today. So anyway, we've got the medial head, which again we're all going to be inserting onto the olecranon process of the ulna. We've got the medial head that comes like this, and then we've got the short head of the triceps, again going up the outside of the humerus and onto the body of the humerus. So it's got that kind of feathering that you can see, and it's the short head, the medial head, and the long head that we have. And then you can think of that classic tricep pose, and they're different. The horseshoe effect is caused by the different size of these muscles, and they can vary on different people, they'll look different. But the main thing with the triceps is that we have these 4 extensors. Some are just local to the humerus, but we have that long head that goes into the shoulder, which is on the lateral border, and the infraglenoid tubercle, like so there. Okay, so guys, elbow questions. Anybody got any questions for Aaron in regards to, let's stop the share. Let's click off of that. Anybody got any questions in regards to the elbow, or pain that they've got right now, or pain with clients? So let's see.
Nothing. Stunned into silence.
Everybody. So, okay, so Rich has said, did a seminar with Australian strength coach, deadlifts with a switch grip, and he says he has a moderate scoliosis as a result. Yep, definitely.
Yeah. I mean, I think from you guys' perspective, the muscles that you're probably likely to come across in terms of the ones that are problematic from a PT perspective are your biaxial muscles. So biceps brachii, because it crosses the elbow joint and the shoulder joints, you either get problems at the distal end, the one that's closest to the elbow, or the proximal end, the one that's closest to the shoulder joints. And then on the back of the arm, triceps. Again, that's a joint which crosses the shoulder joints by the infraglenoid tubercle that Chris was talking about, and onto the olecranon process, which is a bony prominence on the ulna. So I think when you're looking at programming, typically what I see working with the clients that I do, people that have a protracted, rounded shoulder position, and as Chris was talking about, this sternal angle, when they start bench pressing, once they drop below parallel, they often complain of pain in the front delt, which isn't actually pain in the front delt, it's pain in the long head of biceps. And that's because at the bottom of your bench press or your pressing movement, your biceps tendon is maximally stretched and also maximally loaded, so it's passively insufficient. And then in the same token, triceps, and I think that's again either driven by pressing movements and over reliance upon your push movements. You tend to find that pain around about here, just above the elbow joints, that's the common site for tendon problems in your triceps. The question I saw then, Chris.
Yeah, so we've got, I'll go with Matans first, and because I like this question because it makes sense when it says when she does eccentric chin-ups, she gets some pain in her left shoulder. What muscles could be causing that pain? Now, first of all, so where would be the pain, which I'm guessing is going to be anterior, so it's going to be in the front compartment, anterior delt region. I'd guess that'd be it. What I would say from there is that every joint has a push-pull relationship, and everything that's acting on that joint. And when we look at the shoulder, there's so many different things it could be. It could be in the arms, it could be the biceps, triceps, and then the rotator cuff. If she has a weakness in somewhere in the rotator cuff, when she's in that lowering position, she is essentially really, really contracting her biceps hard, eccentrically, to control the lowering. So if she is over contracting her biceps because she has a weakness in the rotator cuff, she's probably got too much contraction going on in somewhere around the biceps region, maybe short head, maybe somewhere around there. That is then causing the head of the humerus to rotate anteriorly, which means that the rotate anteriorly in the joint, which is causing the head of the humerus to either impinge on the capsule or impinge on the nerve, and that's where I would say the pain would be. So she either needs to work on triceps or rotator cuff, because she's I don't want to say it, but I don't want to say bicep dominant, but she's using her biceps or overusing the biceps. And with women, the reason why I think that is important is because a lot of women, especially if they had kids, will hold babies in one arm, or pick up bags with one arm, or basically have a constantly contracted bicep on one side, which they never will notice, but they'll passively become chronically contracted. So that's what I look for. So there's one saying, Aaron, please could you go over the pain above the elbow for triceps pain?
Yeah. What was that? Go over pain above the elbow for triceps. I think we've missed a few as well, Chris. There was one about Ehlers-Danlos, I think, earlier on.
Yeah, cool.
So pain above the elbow for triceps.
Mm-hmm.
Essentially, that's where your long head of triceps tendon attaches. It goes onto the olecranon process, which is the superior part of the ulna. And because of the convergence, it's very much like, as Chris said, the quadricep muscles. All those quadriceps converge onto the quadriceps tendon and then onto the patella tendon. Well, the triceps is the same. You've got three muscles essentially converging on one tendinous point. And that point, biomechanically, is the point where you start to get tendon problems, tendinopathies, tendinitis, tendinosis, that sort of stuff. Does that answer your question, Anthony? Yeah. Right, let's just go back up, Chris, because we've got a few questions.
Is it the EDS, hyperlaxicity? Yeah. For clients with EDS and hyperlaxicity, do you have any specific considerations for internal cues for elbow stabilization in pressing movements?
Right, so for those of you who are not familiar with the term EDS, there's a number of connective tissue disorders which cause laxity and kind of not just a degree of laxity like you might see in some of your female clients, but we're talking about pretty significant joint laxity. So Ehlers-Danlos, EDS, that's Ehlers-Danlos syndrome. And interestingly, I think this is one of those conditions that it's often undiagnosed. So I think people often have joint laxity, quite high degrees of joint laxity, and because the clinical testing of EDS isn't yet sensitive enough, I think there's probably a lot more people walking around with EDS than we perhaps appreciate. The other one that goes with that is Marfan's. There's another condition called Marfan syndrome. And again, that's another connective tissue disorder. These guys usually have really long spidery fingers because it starts to affect the joint mechanics. So their digits become kind of very long. Do you have any specific considerations or internal cues for elbow stabilization in pressing movements? Personally, I don't know whether you do, Chris. I mean, I think from a training perspective, what I'd be doing with these guys, I'd be doing a lot of proprioceptive type work, because I think it's usually neuromuscular control. If you think about the role of ligaments, so ligaments, yes, they connect bone to bone and they're there to stabilize the joint. A ligament is a a structure that has a high degree of proprioceptive nerve endings in it. And what you find that does is it relays information about the position of the joint back to the central nervous system. So I think when you're rehabbing somebody with ligament problems, I tend to use unstable surfaces, changing the base of support, changing the stimulus that you're using to create load. That might be using kettlebells upside down. So you're starting to create a degree of instability whilst you're working through there. Any thoughts from you, Chris?
Yeah, I mean, what I would say is that type of thing definitely has its place. I'd say just as simple as just tempo, like you say, when it comes to proprioception. I think the problem is that, it's fantastic when you've got a guy who's in his mid-20s and very, very strong and stable, for him to say, right now, contract your chest or whatever you dealt as hard as you can. That's a great cue for him if he wants bodybuilding, because he's getting a lot of neural feedback. But for people who are when they have very, very poor proprioception, which somebody with that type of issue have, would have, I think that the main thing that you want to do is, I would slow things down from a tempo perspective, where you just get them to pause, because it's for safety reasons, is you want to make sure that they're never in that point where they're getting vulnerable from a joint perspective, and then they suddenly they lose stability, and then could possibly irritate that joint, because obviously they've got unstable joints to begin with. So I just say tempos and pauses. But what you said there, 100% unstable, but unstable to a degree in which they have the ability to do it. Because I think if I said to any guy, any girl, watching this, grab a kettlebell upside down and press it, the way you do it with a 16 kilo kettlebell and the way you do it with a 4 kilo kettlebell would be completely different from muscle recruitment perspective. So lower intensities but harder variations make some things hard. So if that makes sense, so she wouldn't really need much load, but that type of unstable surface would be amazing, as long as she can do it well. So guys, sorry, there's quite a few, but we're going to just do one more question before we go on to the shoulder. So apologies to anybody who hasn't, because I think this could go on for a while, and we will go on to the shoulder itself. We'll just go with this one. Had surgery in left shoulder, which where he took out part of the bicep tendon. Now it affects range of motion, internal rotation, instability of the shoulder, pressing, grip fatigue, and development of all the muscles on the upper left hand side. Okay. So in terms of training around that, what would you say, Aaron?
Was it I mean, I'd like to know whether that was a labral repair, whether it was a slack lesion, and whether they've taken the biceps tendon out because of it was damaged as part of the labral tear. Again, I think it's about creating effective motor patterns. So you'd want to basically make sure that you were trying to retrain the movements, get the scapula stabilized, build some strength in serratus anterior, middle and lower fibers of trap, so you've got that stable base to work from. And then again, the instability. You've lost a degree of proprioceptive feedback with that removal of the biceps tendon, and that they've gone into probably the shoulder joints. And the shoulder capsule provides a lot of information regarding the position of the joint. So I think similar principles to what we talked about with the EDS people. But yeah, I'd like to ask a few more questions on that one before I could give you a definitive answer.
Cool. Okay, guys. What I'll do is I'll export the chat, because there's a few questions that didn't get answered, and we'll look at those. Probably use it maybe for a Q&A another time, because I'm wary of the time. If anybody does have to get off at 3, don't worry about it. If you want to stick around for the live show, then it's absolutely fine. Because I do want to go into the shoulder, because I know it would be, we could finish there and go into next week, but whilst this is fresh in your mind, I do think this would really help, and it may help you also with connecting a few dots in regards to how everything integrates, and the integration of these muscles is really, really key. So you cannot minimize. All right. I cannot minimize. Right. So we are going to go back into a screen share. So let's share the screen again, and let's get back into here. Where was I? It was at the whiteboard. Let's play. Okay. So the rotator cuff. So we get all these different ways of remembering things, and a lot of you will see sits. So remembering those rotator cuff muscles. So which muscles act on the rotator cuff? Well, I'd be first of all, what makes it a muscle that acts on the rotator cuff? That's like, why is it a rotator cuff muscle? And answer to that is that it's going to insert on the head of the humerus and either the greater or lesser tubercle. And as you can clearly see there, we have GGGL. And GGGL is just greater, 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 lesser. So we have the supraspinatus, which is going to insert on the greater. We have the infraspinatus, which is on the greater tubercle. We have the Teres Minor, which is the greater tubercle, and then we have the subscapularis, which is on the lesser tubercle. And the reason why, if you just remember GGGL, is that then you know all the insertion points and the muscles. It is so simple because, you know, with the supraspinatus, the infraspinatus, and even with the subscapularis, they all live in a fossa, they all live in a cave. So you now know the origins and insertions of those quite simply. Where they attach, so where they insert either the GGGL, greater, 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 lesser, is going to dictate whether they're primarily in, or classically in textbooks, in a external rotator or an internal rotator. So the greater is going to be an external rotator. Anything that inserts on the greater. Anything on the lesser is going to be an internal rotator. So it's a good differentiation of that. And if we think about that greater and lesser, again, that translates to the greater and lesser trochanter, and we have different ones as well in there. So again, we have that mirror image that's going on in the lower body as well. So we have sits. So if I said what muscles are in the rotator cuff, well, there's lots of muscles that sit in the rotator cuff, so just remember. And then we've got the supraspinatus, we do infraspinatus, so above and below the spine of the scapula, Teres Minor, and we have this the subscapularis. So we want to remember those. Now there shouldn't be any reason not to know if you can just remember GGGL, or, you know, greater, 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 or 3-to-1 external to internal rotation ratio. Now, like I said at the beginning, we have more external rotators, we have more stabilizers, and it's because, in my opinion, we have our internal rotators are our extensors. So that's massive. Like, it makes things a lot clearer. I'll say it again, our extensors are pretty much our internal rotators in regards to moving things forward. When we're thinking about the pec, it's an internal rotator, but it's going to be helping us into that extension movement, which is pushing something away. And if we think about when we're kicking a ball or we're doing anything with our quads and we're pushing something like squatting, we're extending our hip with our glutes, we're extending our knees with our quads, but that they are also acting as an internal rotator, but being cancelled out by the external rotators, and that's what keeps it in a straight line. So there you can understand that stability it comes from a nice balance between external rotators, managing the joint in a very, very deep level, but then the superficial layer, so the layer on top, is extending but acting as an internal rotator as well. So when it comes to the deltoid, so you think muscles of the shoulder, I just like to think of it as the roof on a house, something that goes on top of that rotator cuff. So all those muscles underneath, we have the muscle on top, which is your deltoid. And in some of them, I've seen SACS, the acronym, or the way of the mnemonic is SACS, the way of remembering it. But for me, I just prefer third class, because we've got the image there, but we've got third class. If you can remember the deltoid, third class, however you want to remember that, then you've pretty much got the all of the origins. So we've got the lateral third of the clavicles, third class, clavicle comes first. We've got middle part of the acromion, and we've got the spine of the scapula, so the most distal part of the spine of the scapula, so the outer part. And the interesting thing about that is that it's going to share a lot of the same insertion points as the trapezius, so the trap muscles. And then it's going to go into the deltoid tuberosity, which is laterally on the humerus. So we've got that deltoid tuberosity. And the interesting thing, and again, I know I go on and on and on about it, but if you can remember the kind of principles, then you remember all the muscles. The deltoid to me is the same as the glute min and med, because the glute min is going to be the anterior delt, which has internal rotation capabilities, and the glute med in certain positions is going to have external rotation capabilities. And when people are trying to get that really, really strong pump in the shoulder, where you get that really, really nice shoulder pump, you want to really manage that sweet spot where you're essentially trying to get the lateral and medial fibers, so the posterior medial fibers of the delt, to be externally rotating the shoulder whilst they're also abducting the humerus. And that's why leaning forward and pointing our elbows forward, so now we've got a challenge to external rotation, helps get all the heads of the deltoid nice and evenly. If we're just upright and we're going forward just in a normal abduction, I think that's when we start to bias the anterior fibers. So that's just playing around with your shoulder position. It's because not only are we going to get the abduction quality of the humerus when we're in a certain position, but as soon as we get some external rotation challenge, we start to get the medial and posterior fibers as well. So third class for that one. And then we've got that. Now the other guys, there's the guys that we can't leave out. We're thinking about the shoulder and the arm, because we've got the rotator cuff, we've got the extensors and the flexors, the elbow, and we've got the deltoid on top, but we can't forget some guys which are also important. And we've got the coracobrachialis, which is one we started with. We've got the pectoralis minor. Now, the reason why these are important, because we're talking about the shoulder, so it's anything of the scapula, is these guys form this little triangle, the way I see it, a triangle that helps attach part of the humerus to the rib cage. So it's like a little, it goes in a little, if you think about we're on the anterior part of the humerus, quite near the top, it's going to take a little journey into the coracoid process, and then that same attachment is going to go into the rib cage on ribs 3 to 5, and that's where the Pec Minor is. And these, in my opinion, help steer us into internal rotation and guide us. But it's like this bag strap. The way I think about it is, if you put you've got a bag and you put the strap on over your shoulder, that's what these muscles are doing, because it provides some form of anterior attachment for the scapula to the front of the rib cage. So we've got the coracobrachialis and the pectoralis minor. They do play a role and they are important. And then finally, we've got the Teres Major. Now, the main thing, or the main word for the Teres Major, is just remember inferior. Everything about it is inferior, which doesn't sound too nice. It's a bigger muscle than the Teres Minor. However, if it's on the inferior border and the inferior to the inferior angle of the scapula from a posterior perspective, and it's going to go into the intertubercular groove, so this little gap in between the Pec Major and the lat. So essentially it's just a little lat. It's a guiding muscle to assist in the same functions that the lat will. And if you think about the size of the lat itself and all the other things it has to do, it helps to have this little manager with it, which is essentially running in the same direction as the fibers. But also, as the lat doesn't really act on, it doesn't act on the scapula at all. Some people it might clip the inferior border, some people it won't. But because the lats don't act on the scapula, the Teres Major, in my opinion, is helping the lat and the scapula have some sort of relationship in terms of shoulder management. So if we're looking from this perspective of so we're looking at what you need to remember. We've got 4 flexors, 4 extensors. We've got 4 rotator cuff muscles. Something that sits on top, so the deltoid, you'll never forget the deltoid, but now you can never forget the origin, because you just remember third class. And then we've got 3 little managers, the other guys who aren't part of the rotator cuff, they aren't part of the flexors of the elbow. However, they do help us integrate the system together and provide some sort of attachment sites to the rib cage and the scapula, to the anterior parts of the body. Right, so we've got quiz. Rather than do the quiz and try and catch everyone out, I'm going to stop the share and we'll head back over to Aaron. We'll just do the Q&A. We've got one here. We've got found a client with a previous Found a client with a previous shoulder problem which seems stronger now. The pain in the anterior region of the shoulder don't seem deep. Pain during movements such as cable, overhead, tricep extension. Okay, cool. We reduced the angle and the weight to something manageable and looked at working the shoulder moving into that movement. Is this the right? Is this right? Any ideas? So let's go through that one again. Seems stretched. So anterior region of the shoulder and delt seem deep. Pain during movements such as cable, overhead, tricep extensions. Okay, so if the pain's coming from the ability to get their arms overhead, and we could go down any type of route here, but the main thing with that when in the overhead position is you could kind of argue that the tricep doesn't have the ability to lengthen to a degree. This one, we could go down so many different routes, but one mistake that I made from a either rehab perspective or from a exercise prescription perspective is assuming that the more length tension you can create in the long head of the tricep, the healthier the shoulder. And that kind of is the case, but with general population people, if they fail a test, which is a simple shoulder flexion test, and they struggle to get their arms above their head, there's so many different things going from a scapular and thoracic and, perspective. So what I would say is that you just put them in a position where they didn't have the ability to contract the triceps or long head of the triceps due to the shoulder position. So what I would probably have said is that you just had the right thinking, is just change the angle so it's not as aggressive in the long head. But again, there's loads of different routes we could go down with that.
It's probably worth, I'd have a look at the active insufficiency, passive insufficiency terms.
Mm-hmm.
When a muscle's in a lengthened position, it becomes passively insufficient. So I think on Chris's point, I think when you're in that overhead position, when the triceps is pretty much fully lengthened, it's passively insufficient. So from a joint, I think of the triceps almost like the fifth rotator cuff because of its infraglenoid tubercle attachment. Mm-hmm. So the biceps is the sixth rotator cuff, biceps brachii. So I think when you're in that position, triceps is lengthened, you've lost a degree of that posterior stability. So now the anterior part of the joint is having to sort of compensate. And it's due to this passive insufficiency when a muscle's lengthened and loaded.
Mm. But yeah, it was a really good question, Sam. But we could go. It's in terms of reducing the angle. That is right. So your thought process in the right idea there. It's just that what I would say is that don't take textbooks as the gospel. As like, well, we can all cope with this. Is now a really, really good tricep exercise because you might have to meet them in the middle. And what you might find is you get more of a neurological stimulus and the blood flow to the area. They actually increase the range of motion per set. So if I had someone with tight shoulders or tight triceps and I want to lengthen it, I would start them somewhere where they have complete control to contract and then change the level of the cable as we go per set to a degree where they can still feel it, until something else starts to kick in. So the thing that I'm big into is not solid programming. You have an idea of what you want to achieve, but that exercise setup may change on the day, depends on what the person comes in with. So we've got two which kind of fall into the same category. Static postural assessment, what might be causing one side to be, the shoulder to be higher than the other side. Female client with an elevated shoulder, left trap looks like it's contracted. Pain associated with pronated pressing overhead. So we've got uneven shoulders. I'll let you go first, Aaron, because...
So I think, and this is kind of historical, what you tend to find when you get shoulder problems, and this might be that kind of subclinical, little bit of a pinch now and again in the shoulder, or a bit of clicking in the shoulder, you tend to find your shoulder starts to develop what they call a capsular pattern. So it starts to internally rotate and adduct, because that's the position where you're taking a lot of the structures around the shoulder off stretch. So if you've got a hot, squealy shoulder, and the body naturally adopts this capsular pattern. Now what that does is it changes the position of the scapula. The scapula now starts to migrate around the rib cage. It starts to come forwards. That reduces the space under which the supraspinatus tendon runs underneath the acromion process. And as a result, you start to change what they call a scapulohumeral rhythm, which is based on the movement of the scapula and the humerus. Now, because it's painful, or because you find you've got some pinch and some impingement when you're raising your arm out to the side or to the front, you tend to find that your upper trap starts to initiate the abductional flexion movements, and that's why you start to get increased tone in that upper trap. So it looks more toned, it looks bigger, or lower in comparison to the other side. And it's all because of the changes in the scapular stabilizers. So typically in those situations, working on serratus anterior, working on the middle and lower fibers of traps, building some stability and some strength in those muscles, and maybe doing some stuff to inhibit the action of upper traps, some lacrosse ball, some trigger point therapy into that, some taping across the fiber direction to make the muscle less active neurologically. Those things would work to try and address that imbalance and any pain you get.
I think like a great, not a great exercise, but an exercise that tells you a lot about that is when people do lateral raises and the traps burn like hell and they get very, very little delt.
Yeah.
If that's the case, then that's a really, really good, that's a really clear indication that what Aaron just said there is occurring. And scapulohumeral rhythm, because if you think about all the other things that we do, and I'm a big believer in like cross referencing or kind of carryovers from exercises, is that if somebody's doing a load of really heavy deadlifts, I'm not saying this person is, but they've done something heavy, either a trap bar or anything that's put a lot of taxation on that trapezius muscle, that muscle might be so efficient or now hypertrophied that it's going to want to kind of take over, or it's going to be dominant in a lot of things, and especially in scapulohumeral rhythm, I think, because what I found is I didn't really, that's from personal experience, but it makes a lot of sense from an anatomy perspective, because I found that the more I did loads of deadlifts, I could never feel my delts doing any type of lateral raises. It was just all wanted to come into my neck.
Yeah.
And that's because your traps have become so overdeveloped and they've taken that away. So it does become difficult. That's where you could possibly play around. That's when it's really, really useful to understand exercise mechanics. So like any of your RTS muscle mentor stuff is fantastic, because then you can see about how applying a drop off can be really, really efficient. So when you're taking it through that strongest point, I'm really big fan of like METs, or what you'd say is isometrics or PNF. But what you'd want to do is trying to encourage someone to relax the shoulders, and you'd have their arms by the side and maybe just get them to push into you to a degree to try and stimulate a little bit of the supraspinatus, which is going to initiate that first however many degrees is the first 30
degrees. Yeah, first 30.
First 30
I mean, it's active all the way through. It just initiates.
Yeah, it just the initial moment, because it's what you essentially want is you want this tiny little bit of upward rotation. Downward rotation initiated by the upper traps to be co-contracted with the supraspinatus at the same time. So you need that timing sequence, so you can just orientate the scapula just into a position where then the supraspinatus can then contract to restart that adduction movement in the humerus. They need to be able to co-contract, and then we can go through, then the delt can kick in, and then the upper traps finish off the movement. And that's really important if we think about that frontal plane movement during a lateral raise. And it's that sequence we want to work on. The issue that, like Aaron said, is that it just becomes all upper trap with the whole point. You have very, very little rotator cuff and rotator cuff recruitment, and sometimes deltoid recruitment. In regards to, sorry, this one, my quick take on shoulder height is that's you could go down a rabbit hole with that, but it just depends on the person. A lot of it can come from I do really believe that shoulders can also be the hips and pelvis can have play a big role in that. Just depends what they do. If they sit at a desk all the time, probably not. But if they've done a sport, or they squat, or they deadlift, or they're doing something, I do think it can kind of cause some issues there. No problem. So we'll do two more, guys. We'll go through. I know a few people are having to get going, but do a couple more questions. So, any thoughts on trying to keep the shoulder depressed when performing a lateral raise to prevent the upper traps doing too much of the work, or is it vital to ensure upward rotation of the shoulder blade whilst performing the raise for shoulder health reasons? Aaron, do you want to go first with that one?
Yeah, I would say either keeping the shoulders depressed or reducing the range of abduction movements, because it's usually once you come above 90 degrees, if we look at the EMG studies into when upper trap starts to become more active. So EMG is basically electrical activity. We put surface mounted pads on or needles into the muscle to work out when the muscle's most active. It's usually above this 90-degree point. So for most people I work with, we tend to lat raise just below 90 degrees to keep the upper traps out of the equation. And if you're struggling with that, then yes, try and keep the shoulders depressed as you're going into your lat raise. Either technique would work.
Yeah, with that one, in terms of keeping the shoulder depressed, I think that there's a load of good theories. It just depends on the skill set of the client. So I think that Aaron absolutely nailed it in the podcast that we did on shoulder health. One of the best exercises that I think you can do for the shoulder is the Arnold kettlebell press. Because if you think about it, we're taking it through a more natural range for some reason whatsoever. You know, the bodybuilding world. You know, I love how Aaron you know, talks about evolution quite a lot. But if you think about bodybuilding and the period of time it's been around versus the evolution, you know, the past how many years we've been evolving for. We do movements which we've attached ourselves to. I'm not saying we're not designed to do it. We're designed to do a lot of things, but the issue that you've got is that it's not supporting what that scapula has the capability to do, which essentially is more of a front crawl motion or a climbing or a crawling motion. So it wants to go through kind of like a circumduction. And what I like about the fact that if you're going through that full range of motion, going from the front of the body moving round, you're getting a lot more serratus anterior, you're getting a lot more like stimulus to different heads of the deltoid. I think from the ranges that you access, you take the traps from a length into shortened position. So I would just say, whilst, you know, if you're unfortunate to have access to either a small dumbbell or a kettlebell whilst we're in lockdown at the moment, at the end of a shoulder workout, just pick up a really, really light dumbbell, like 4 or 6, and do 30 really, really controlled Arnold presses and see how your shoulder feels. But have really, really good focus on your breathing and how you engage your serratus anterior and where your rib cage is going. Do that, see how your shoulder feels. And you might start to lean towards them rather than heavy dumbbell lateral raises with clients. I think a lot of shoulder impingements and injuries would be managed better if people weren't as attached to lateral raises and did exercises a little bit more like that. Cool. I'm gonna do the last one. Rach, 6 years after an ACL grade 2 separation and grade 2 slap tears, I still get some pain and posterior blocking around my Teres Minor. Is there any rehab that I benefit from despite my pressing having improved? So, what are you thinking of that one?
So I think the first thing I'd think about, so acromioclavicular separation is what we're talking about here. So essentially, the acromioclavicular joint is stabilized by superior and inferior acromioclavicular ligaments. And usually it's a fall onto an elbow, fall onto an outstretched arm, a forced arm, forced back into horizontal extension. That's what separates the clavicle from the acromion. And then the slap tear, basically there's a fibrocartilage labrum that goes around the joints, and a slap lesion is a tear of the superior part of the labrum. Now, although your strength might be back, what you'll often find when joints have been sprained and they're the ligaments have been loosened, like it would be in the separation, you often find the joint gets stuck in a certain position. So human movement is composed of physiological movements. That's like flexion, extension. Inside the joints, we have these things called accessory movements, which is the spin or the roll or the glide of the bones across each other. So usually in those situations, if you were to find the edge of your clavicle and do either an anterior to posterior glide or a posterior to anterior glide to improve the roll and spin of the bones, you'd find that would take a lot of the movements, discomfort, posterior part of your shoulder away. If that doesn't work, I'd probably then consider the fact that maybe there's a little bit of a bony spur that's developed as a result of the labral tear, and that might be impinging on the back of the shoulder.
No, that's awesome, and I think that you really hit the nail on the head there in some of these issues. And even though, you know, especially from your perspective, Aaron, it seems like, you know, you've got an agenda, but some things just do need treatment. And if you understand that, is that, like, I'd love to say that, yeah, you can out move or you can out program an injury, but sometimes if there is restriction, I'm looking at that, and I'll be honest with you, I can't think of an exercise which should appropriately be able to do that because of the intricacy of it. You might need to self-mobilize and then think about your exercise progressions. But I definitely couldn't say, here's this, and then that'll address that. That would be some sort of soft tissue manipulation to improve it.
It's a joint that doesn't move. Like, from an exercise perspective, it's an integral part of your shoulder girdle and therefore your shoulder joints. But all it basically does is it just rotates around a fixed axis, both the lateral end and the medial end. So in terms of muscles that attach onto there aren't any. There's a lot that attach around it. And this is why AC separation is such a problematic thing to treat, because you find once it's separated, what we ideally would like to do is use the muscles that surround that to pull the clavicle back down again. But because there are no direct attachment from the muscles onto that joint, we're kind of reliant upon limiting our end range of movement, further spraining the ligament, further separating that ligament to treat these things. But yeah, there's some situation, I think, as you quite rightly said, Chris, where hands-on treatments or self-treatments, there's no substitute for.
And if you can understand that and you are educated in that, then you're onto a winner, because it just becomes a case of spend a little time doing this, not necessarily before your training, because that can be a little bit risky, but around about certain times, you know, before or after, or the day after training, to help manage it. So yeah, guys, what I'm going to do is, because I appreciate, we know we're going quite far into it, just want to say thank you for coming on to this one. It's been great. We're going to do the lower body, so muscles of the hip and the thighs, and the upper portion of the thighs next week. I've just popped in a link into the, nope, let's go there. Nope, I want this to be in the group to everyone. So I'm just going to pop in a link in the chat there. Absolutely no obligation, but if anyone wants to give a $5 to that, for it's the gym where I work is raising money for the NHS. It's just a private gym, fundraiser account. Whatever you want to donate is absolutely fine, but we're nearly at the target. I'd love to hit it before we all do end up going back to work, but if anyone wants to have $5, any type of donation, but the link's there. It's for a local hospital, just for the staff there, to support them during the time. Apart from that, just want to say thank you very much, everyone, for watching. I'm going to now put this onto YouTube, so then you can find the link there. And then, yeah, same time next week. And Aaron, if you want to join me, we can do the same again.
Yeah, perfect.
Yeah, no pressure. Brilliant. Awesome, guys. Thanks very much. And I will see you all soon.